Good evening. Welcome to tonight's Global Public Health Lecture. This lecture series is co-sponsored by the External Advisory Committee of the Global Public Health Program and the Institute for Health and Humanities. We're very thankful as well for a grant from the Montana Community Access Television, that enables us to videotape these presentations and then show them to people who couldn't be here tonight. We're very privileged tonight to have Deb Goldman with us, and she has many years of experience in clinical advanced nursing practice, in research and training of a variety of health professionals, both locally and globally. She received a Women's Health and Adult Primary Care Nurse Practitioner Certificate at Harbor, UCLA, a Master's of Science in Nursing at California State University, Long Beach, a Master's in Public Health at the University of Washington, and a postgraduate Certified Nurse Midwifery Certificate at Seattle University. Deb has recently served 3 years with Global Health Service Partnership in Tanzania, teaching nurse midwifery. Her global health work includes training nurses in HIV care in India, China, Namibia, and Uganda. She spent 2 years in rural Alaska training community health workers for women's health care. Deb is a passionate advocate for providing all women with access to quality women's health care services. And I'd like to give a shout out to Gail Pullman for being the contact person on the External Advisory Committee that set us in touch with Deb. Gail has also, of course, as you know, worked in Tanzania. I don't know, is that where you met?
Yes.
All right. And so we thank you so much for coming all the way from Seattle to be here to share with us your insights on this important topic. So please join me in welcoming Deb Goldman.
Honestly, I did not bring the rain. So, yes, Gail and I met in Tanzania with a Global Health Service Partnership, which was a collaboration with the Peace Corps and an NGO out of Boston called Seed Global Health. And we had an amazing group of volunteers, doctors, nurses, and nurse midwives teaching medicine and nursing in several African countries. So I'll talk a little bit more about that program. Okay. So what I'm doing now is more consultant work. I'm retired from actual clinical work after many, many years, but still doing some volunteer global health work, which I'll talk about. Oops, wrong button. So Leah Kabede, not sure if that's how you say her name. She is actually a famous model from Ethiopia who is an advocate for safe maternity care, has an NGO. And she says, every day we hear about the dangers of cancer, heart disease, and AIDS. But how many of us realize that in much of the world, the act of giving life to a child is still the biggest killer of women of childbearing age? So I call this a global disgrace. Most of these deaths are preventable. So pregnancy-related complications are the leading cause of death for women between the age of 15 and 49 worldwide. And every day, 830 women die from preventable causes related to pregnancy and childbirth. Every year, 2.7 million babies die within 1 month of being born. So we could talk about infant mortality, but that would be another whole lecture. So we're going to focus on maternal mortality today. 99% of all maternal deaths occur in developing countries, and maternal mortality is higher in rural areas and even in some urban areas where poverty is rampant. I hope you can see this map. The light pink area shows, I don't really have a pointer, but you can see here, the light pink countries have 1 to 19 maternal deaths per 100,000 live births. And then as the colors get darker, those countries have more maternal deaths. So you can see, especially the continent of Africa. Okay, so how does the United States compare? And these are statistics from the World Health Organization from 2015, the most recent statistics that we have. And we're doing a pretty lousy job with 14 per 100,000. And you can see all of those countries that are way ahead of us. 3 per 100,000, 4, 5, 6, 7, 10, 12. We're not doing so good. And then some of the middle income countries, Russia 25, China 27, India 174. And then some of the highest maternal mortality are in Central Africa Republic, 882 per 100,000, Chad, Nigeria, South Sudan. These are the universal causes of maternal death: bleeding, infection, high blood pressure associated with pregnancy, prolonged or obstructed labor, and complications from unsafe abortion. And like I said before, most of these deaths are preventable. I'm going to show you a short video here.
In 1988, the World Health Organization made a film based on a lecture by the obstetrician Professor Mahmoud Fatala. Its aim was to raise awareness of the millions of women and babies dying each year from pregnancy and childbirth. The film told the story of one such mother, Mrs. X. It was called, "Why Did Mrs. X Die?" Since then, there have been significant improvements in maternal health, yet by no means enough. In some places, things have hardly changed. Women and their babies are still dying needlessly. This is why the story of Mrs. X must be retold. This is the story of a mother called Mrs. X. Mrs. X could have come from anywhere, but she is most likely to have come from a low-income family in a poor country. Mrs. X represents a universal mother. Mrs. X died in a small hospital, 8 months pregnant. The doctor had no doubt about the cause of her death: a hemorrhage. Her placenta had been too low down in her uterus and hadn't been identified in time. The doctor recorded her death, closed her file, and added it to a growing stack of similar cases locked away in a cupboard. Over time, these stacks grew and grew. Some years later, worried about the high numbers of mothers dying in their hospital, the staff reviewed the cases to learn lessons and make improvements. They reopened and reviewed file after file. One of these was that of Mrs. X. When they read it, they found two striking points. First, Mrs. X had arrived at the hospital bleeding heavily, yet she only received half a litre of blood. This was all the hospital had available, and it was not enough. Second, Mrs. X and her baby needed a caesarean section, but resources were limited, and the operation took place 3 hours too late. Both Mrs. X and her unborn baby died. The group then visited Mrs. X's village and spoke with her family, neighbours and community leaders. They found that there were other reasons for her death. Mrs. X had a history of bleeding early in pregnancy, but wasn't aware that this was a danger sign needing attention. She also had had only one antenatal visit. If she'd gone regularly, her problem may have been picked up. She would have been referred to a specialist, and she and her baby could have survived. Mrs. X was also severely anemic, so the loss of even the smallest amount of blood, as little as a cupful, could have tipped the balance between life and death. The team discovered that it had taken 6 hours to collect enough money to pay for her transport to the hospital. As a result of these findings, the hospital improved their blood supplies, updated their emergency procedures, and caesarean sections could now be performed as soon as was necessary. The local health department provided more midwives in more places to enable more women to have access to good maternity services throughout their pregnancy and birth. Mrs. X's file was closed again. A year later, a group of visiting health professionals came to the hospital as part of a national inquiry into maternal deaths. They wanted to understand what lay behind the statistics, beyond the numbers, and discover the wider social and economic reasons for the deaths of women like Mrs. X and their babies, and what could be done about it. The aim of their work was to recommend changes to the national or regional policies and strategies to improve women's health and to save mothers' lives. When they reviewed all their data, common patterns emerged. They found most mothers' stories were similar to that of Mrs. X. Like many women in developing countries, Mrs. X worked day and night to care and provide for her family. She was illiterate. She lived in poverty in a remote village. She was unable to choose when and if to become pregnant. Mrs. X was also weak and unhealthy. In her society, the male members of the family came first in the queue for food, for education, and for healthcare. Mrs. X often went without. For women like her, death or complications in pregnancy were, and still are, a real threat. By uncovering the stories of women like Mrs. X, the national team were able to put pressure on the government to provide more education for girls, more resources and staff for maternity care, and better reproductive health services. They also pushed for raising community awareness about health, nutrition, family planning, and the benefits of skilled maternity care. Mrs. X started on the pathway of her pregnancy exhausted, with few physical reserves. She hadn't chosen to become pregnant. It was her destiny. The only value she had to her family and community was her ability to produce children. However, Mrs. X had been lucky in a way. At least she'd had a childhood. In some societies, girls are married off while still children themselves, not physically or mentally prepared for childbirth or motherhood. If Mrs. X had been treated as an equal to her brothers while she was growing up, she could have been healthier and better educated. If she had more control over her adult life, she may have been able to choose when she had children. As Mrs. X continued her walk through pregnancy, her prospects would have been better if she had visited a skilled professional health worker, a midwife or doctor. Even if Mrs. X had known the importance of antenatal care, her midwife was many miles walk away. If only Mrs. X's problems had been recognized and her anemia treated. If only she'd had specialist care in time. Because of tradition, poverty, and lack of knowledge, many women in Mrs. X's community gave birth at home. Some told stories of being treated harshly and disrespectfully by the hospital staff. Some were expected to pay bribes. Mrs. X had also planned to give birth at home, but then she developed a life-threatening complication. She started to bleed. If Mrs. X had been referred and had transport in time to go to a hospital with facilities for providing comprehensive emergency obstetric care, such as equipment, well-trained staff, and enough medicines and blood, her life, and that of her baby, might have been saved. Mrs. X could have lived to raise her children. After the long delay in finding transport, Mrs. X was eventually admitted to the hospital, where, due to the lack of resources, she and her baby died. Along the pathway of her pregnancy, Mrs. X faced barriers that prevented her from receiving the care she needed. Each could have been removed. And yet, many or all of these barriers remain along the roads taken by women today. Mrs. X could be any woman. Your sister, your wife, your mother, your daughter. You. It is up to all of us, no matter where we live, who we are or what we do, to help remove these barriers for Mrs. X and the millions of pregnant women like her. As individuals, we can lobby for better health care and equal rights for girls and women. As communities, we can make sure our pregnant women are informed and cared for. We can organize local education, support and transport for our mothers. As healthcare workers, we can provide quality care in a respectful environment, and we can continue to open the files and learn the lessons from mothers like Mrs. X. As local health planners, we can provide high-quality maternity and family planning services that reach out to more women. And as politicians and policy makers, we can strengthen human rights. We can improve education for girls and women. And we can provide the resources for better, more effective healthcare services across the world, wherever they're needed, now.
Okay, so we're going to do a quick little exercise here. I'm going to give you 2 minutes to work in groups of 2 or 3. Have somebody write down from the film, from your classes, what you've learned about social determinants of health, your experiences, and just make a list of why did Mrs. X die? And not because she had a placenta previa. We know that that's the medical cause. Whoops. You guys want to get together? So work together. Just brainstorm, list them, and I'm going to give you 2 minutes starting now. Okay, time's up. Let's go around the room and just shout out one reason why Mrs. X died?
Gender inequality.
Gender inequality. Lack of education.
Lack of healthcare infrastructure.
Lack of what?
Healthcare infrastructure.
Lack of healthcare infrastructure.
Lack of adequate access to family planning.
Adequate access. Lack of adequate access to family planning. Good.
Inadequate social support.
Inadequate social support.
No family planning.
No family planning.
Malnutrition.
Malnutrition. Good.
Immediate medical care.
No immediate medical care.
Being a woman.
Being a woman.
Lack of transportation.
Lack of transportation.
Lack of resources.
Lack of resources.
Paternal societal.
Material and human healthcare providers. Somebody say something else?
Paternal societal.
Poverty.
Paternal society.
Paternal society.
Patriarchy.
Patriarchal society, yeah.
Skilled healthcare providers.
Lack of skilled healthcare providers. Okay, good. I think you've covered just about all of them here. We've got poor socioeconomic development, no clinic nearby, no transport, poor no roads, excessive fertility, having too many babies, too young, lack of education, hunger, dirty water, no cash, no hospital, no help, life-threatening complications, bleeding, high-risk pregnancy, delay. So turn your papers over now, and I'll give you 2 minutes to brainstorm. So what would be some solutions? Okay, go. Okay. Same thing. Just shout them out.
Access to family planning.
Access to family planning.
Increase mid-level practitioners.
Increase
Practitioners in general.
midwives, clinical officers,
Women's rights.
skilled healthcare providers. Women's rights with kind of a general term, but
Breastfeeding.
Education of women.
education of women.
And of men.
And of men, yeah.
Education in general. Transportation.
Transportation, emergency backup plans.
Build more infrastructure. Build more health infrastructure.
Increase the healthcare infrastructure.
Nutrition education is a value and why women are valued.
Social cultural change around how women are valued. Good.
Getting married at early age, not because of early age marriages. To get married at early age.
To get married at an older age.
Yeah, older
To
age.
get pregnant at an older age.
Breastfeeding
Breastfeeding?
just prolongs the time that you're not getting pregnant.
Oh, prolonged breastfeeding can be a method of birth control. Good. Okay. We'll just review some of the ones I have. I mean, this would be a whole class in figuring out solutions to this, but more skilled health workers, more midwives, better training, higher salaries for healthcare workers, transport, systems change, infrastructure, drugs, equipment, supplies, raising the status of women, educating girls, accessible family planning, accessible community-based maternity services, accessible first-level referral services, and on and on. Okay, so what I want to do is show you a short 2-minute video, because to me, the pictures are worth 1,000 words. And this video shows a midwife who's practicing in rural Tanzania and what her challenges are. And I could name them, but I think this short video will be better. This is Elvina.
Kazini ikishafika pale asubuhi nafanya usafi na andaa vyombo vyangu vya kuwazalisha mama wajawazito na vya kuhudumia watoto wachanga wanaozaliwa. Sawa, naongea. Ninafanya usafi kwa sababu wakunga tuko wachache, kwa hiyo kazi hii inanibidi mimi peke yangu fanye shughuli zote. Fanya usafi, naandaa vyombo hivi vya kuzalisha kina mama. Na baada mama akija, mimi huyo inabidi nimshughulikie, nimzalishe, nitunze kumbukumbu kwenye vitabu. Ambapo tulikuwa wengi tunaweza kusaidiana, mmoja atafanya hili na mwingine anafanya. Na kwa sasa hivi inategemea kupata kina mama wengine hata 6, hata 10. Yaani maki mchana kutoka usiku kucha. Throughout the day. Nikishatoka kule kazini nasema kwa kama mama tu nyumbani. Nikishakuja hapa inabidi niandaliwe jikoni chakula. Baada ya kula sio jembe nianze kulima kama mnaona matuta yale pale mmoja analima na kupanda kipato kilomita na kitosheleza kwa mahitaji yangu yote nalima ili kujiongezea kipato. Maisha ya kula ni
So, can you imagine working way more than 40 hours a week at your job and then doing everything from the custodial to the, delivering babies, taking care of emergencies, and then going home, taking care of your grandchildren and farming? So, these are real situations that healthcare providers face in these countries. So where do we stand now? So how many of you are familiar with the Millennium Development Goals from between 1990 and 2015? So the goal 5A in the second bullet point there called for the reduction of maternal mortality ratio by 75% basically between 1990 and 2015. And right now, we improved by 44%, but that's a far cry from 75%. 1990, we had 385, this is sort of the worldwide average, 385 maternal deaths per 100,000 live births. And by 2015, almost cut in half, 216. The annual death toll remains high at 289,000 maternal deaths per year, annual. Most of these deaths, again, could have been prevented. So what is happening in the world to address the unfinished Millennium Development Goals? In 2014, the WHO, World Health Organization, UN, USAID, several organizations met in Bangkok to address and come up with a strategy for improving maternal care called the Global Strategy for Women's, Children's, and Adolescents' Health. So the goal is to reduce global maternal mortality to less than 70 per 100,000 births by 2030. And the vision is a world in which every woman, child, and adolescent in every setting realizes their rights to physical and mental health and well-being, has social and economic opportunities, and is able to participate fully in shaping prosperous and sustainable societies. It's a multifaceted implementation plan. If you're interested in learning more about it, the full report is at who.org. A few of the strategic goals related to maternal health are addressing malnutrition and nutritional needs of children, adolescent girls, and the pregnant and lactating women. Ensure universal access to sexual and reproductive health care services, including family planning and rights. Achieve universal health coverage including financial risk protection and access to quality essential services, medicines, and vaccines. So these are the guiding principles behind the strategy. It should be country-led. I know Gail was telling me in some of your lectures they've talked a lot about, how as much as we've learned, we still tend to go into countries and tell people what to do. Imperialism. So they're trying to develop a strategy that avoids that paradigm and gives countries the leadership around what they need and how they can strategize, giving them some guidance. Sustainable and human rights based. There's a big push to talk about equity for women, gender responsiveness, evidence informed. This could be another whole class. Partnership driven, people and community centered, with accountability. Again, I'm going to show you another short video that's the human rights based. Oh, go ahead.
Partnership driven, is that partnership between provider and patient, or is that a different partnership?
It's partnership between, in a community, between, in a country. So from the top Ministry of Health to the healthcare organization and the director, the healthcare providers, the community. So the partnerships among people in the country, people in each community. And partnerships with organizations that can help with funding and guidance. So this video is about the right to respectful maternity care. So the White Ribbon Alliance is an organization that's doing a lot for advocating for rights of women around maternity care. Whoops, sorry. I didn't mean to do that. So White Ribbon Alliance, this is so true. When women are healthy, so are their children, families, communities, and countries. The White Ribbon Alliance understands the synergy between sexual, reproductive, maternal, newborn, child, and adolescent health policies and services and implements a more holistic solution. We envision a world where all girls and women realize their right to quality health and well-being. And again, our mission of activating a people-led movement for reproductive, maternal, and newborn health and rights. JPIGO is the Johns Hopkins Program on International Education in Gynecology and Obstetrics. And they have a whole series of modules for training providers in obstetrical emergency and newborn resuscitation, helping mothers survive and helping babies survive. That's what I'm involved in now. I've been to several countries to help train local providers in providing the emergency stimulation trainings at sites. A study was conducted on doing just that, delivering training to nurses and midwives in the healthcare facility where they're working, where they deliver babies. And they found that the women and the newborns have safer births. The trainings feature shortened simulation-based lessons with support for practice. So the idea is to go in to train the providers with a very interactive simulation training where they have to save the mother that's bleeding to death or save the mother that's having a seizure because of her blood pressure so high. So they have an opportunity to practice saving mothers in a safe setting, and they work as a team with the people that they normally work with day in and day out. And then the other aspect is to help them come up with a plan to continue on-site practice. And according to this study, these lessons led to a 17% decrease in postpartum hemorrhage after birth, bleeding after birth, a 47% decrease in retained placenta, another cause of bleeding, a 34% decrease in stillbirth. These are significant changes, and this was done in Uganda. 62% decrease in newborn death across 125 public facilities. So this is a pretty amazing training, and I love doing it. It's really fun because it's so interactive. And the Global Health Service Partnership that Gail and I worked at, this was a partnership. It was a 5-year grant with Seed Global Health and the Peace Corps. In the first 5 years, they sent 191 nurses and physician educators to 5 countries: Tanzania, Uganda, Malawi, Swaziland, and Liberia, with 23 nursing and medical specialties. In those 5 years, 704 courses and trainings, 13,000 trainees, 227 service hours. And this wheel kind of shows you what the impact was for strengthening educational environment, promoting students' professional growth and development, delivering quality education. And I'm sure Gail would agree with me, this was not without its challenges, but it was also extremely rewarding. So the Seed Global Health invests in monitoring and evaluation in order to try and determine as much as possible what the impact is. 5 core areas, those are the areas that they're focusing on. They also work with ministries of health and the university administrations to develop policies for improving the status of healthcare providers and making good policy decisions. Seed Global Health, so after the first 5 years, Peace Corps has been, their funding has been cut drastically with our current administration, and so the Global Health Service Partnership disbanded, but Seed Global Health has gotten some funding, and they're continuing their work to send nurses and doctors, if any of you are healthcare providers that are interested in going to serve for a year to teach in either medicine or nursing in, I think they're going to start out with 3 countries.
So is it a part of the Peace Corps, or is it a sect of?
Now it's no longer a part of the Peace Corps. It was, but now it's Seed Global Health is doing this on their own. I think Peace Corps has developed a program. I mean, they really did like being able to do this, but because of their funding issues, it just didn't work out for them anymore. But I think they're still doing short-term Peace Corps response programs, but it's teaching only. They're not allowed to do any of the clinical mentoring piece, which we were able to do, which to me was the most gratifying part of this particular service. But
what were the countries you said they were going to see Global is going to work in these countries?
They're going to work in Uganda, Malawi, and Zambia. Those to start with, and hopefully then they'll increase. You know.
Is it all volunteer work? Like,
it's volunteer work, but they do give you a living stipend plus. A living stipend and a professional stipend.
you have to like pay your own way.
No, they pay all your expenses and provide you with, you know, some Swahili language training if you're in a Swahili country or whatever, and, you know, pay for all of your transportation and training, and they're located in Boston, University of Massachusetts, right? Yeah.
So you and Gail have worked with them.
Yeah.
How do you feel about their ability to support you? Their mission, is this a reputable and organization that you can count on?
I would say yes. We had a lot of support around, because Seed Global Health's portion, the Peace Corps' portion was more logistics. Seed Global Health was about the professional development, and we had always had access to people that were in the U.S. on the ground around professional challenges and professional development.
Do you have any support to the African country, to the French African country, like Central African Republic?
Well, not at this point. I mean, the Seed Global Health goes to countries that they're invited to. So, you know, I don't know from the top what the process is for a country to actually request this kind of help. You could go to the seedglobalhealth.org website, find out contact information, and maybe ask that question.
So, Deb, yes. So the CEO of Seed Global Health is a woman that is a physician, and her name is Vanessa Carey, and her father is John Carey, who is involved politically in the U.S. And she's well supported and well backed by people that have some influence and some brains. So, just have that to say.
So just quickly, my experience, some of the challenges were just, the living situation. The electricity was out, and, my cell phone would die, and, the computer, I'd be trying to develop slides for a class I was going to teach, and power's out, and so, those kinds of issues. Limited human and material resources, and we've talked a lot about that already. And then lack of adequate clinical training. So in most of the countries, it was pretty common for faculty, nursing faculty, especially, to not do clinical teaching. They just did classroom teaching. And there weren't enough nurses to precept. When I was precept as a nurse practitioner and as a midwife, I worked with one nurse or one nurse midwife who was my preceptor, because they were well staffed, so they could train me, but there just isn't that resource. So they're kind of just thrown into the clinical area without adequate clinical training. And the critical thinking skills. Some of the old British education systems in some of these countries are somewhat punitive. So they don't learn to necessarily ask questions or be inquisitive. They're really good at rote memory. They pass the test. They're really smart. But once you give them an opportunity to apply that knowledge in the clinical area, they just rose to the occasion. They were amazing. And abuse and neglect of patients is a real thing. I mean, it's a real thing here in this country. I've seen it here, too. So these are things that are difficult and challenging. Some of the wards, and I know this sounds really trite, to learn, experience another culture, and grow as a nurse and human being in the world. But it's so true. It was just, it changed my life. And the optimism of the students, in spite of the adversity and the conditions and their lack of resources, was just very humbling. The aha moments when they begin to apply their knowledge, that critical thinking piece, and the joy of teaching and learning. And the sense that these students, and I think the physicians had very much, we did a lot of debriefing, had much of the same experiences, that these young doctors and nurses will change the status of healthcare in their countries. And then I'll just show you this short video. I wanted to give you a little background just so you can see what it was like for me, because I can tell you, but again, I'm really into the visual, you can tell. And a little background about this short video I'm going to show you. It's actually slides. There's 3 parts to it, and the first and third parts are basically students in the class, in the skills lab. I was very light on lecture. The activities really solidified learning for these students. And it, sometimes I'd think outside the box, and some of the things I tried were a total flop. But some of them were amazing. The simulation lab was great. And then giving the students some responsibility for their own learning. They're used to kind of being spoon-fed, memorizing everything, and then, passing the test, but not necessarily passing the clinical exams. An example is, I had a question my very first semester, what's the difference between obstetrics and midwifery, or I think that was a question. And about 80% of the students had quoted the slide verbatim. So, these are concepts, these are ideas. I didn't expect that. So it really made me realize where I needed to go with that. And then the second part, International Nurses Day, at least at the facility I worked at, which was in Mwanza, Tanzania. It was a 900-bed referral hospital, Catholic University affiliated with it. And then there was a Ministry of Health. There was a diploma nursing program, a bachelor's degree in nursing at the university level, and a bachelor's degree in nursing education program. So those are the 3 programs that I worked at. So you'll see nurses in pink or blue are students. In white, they're staff nurses. And then they have a parade, then they have like an award ceremony. The nurses are allowed to get up and give their grievances and a list of their wishes to the administrators. And then they have the local people entertained. So in the region where I was, the Sukuma tribe was very prevalent. And they do this really cool snake dancing with cobra. Are they cobras? I think they're cobras. Okay, let's just do that real quick. And so I did this for every single one of my classes, but this was the shortest one, so that's why I picked it.
My money they wait for you, baby. Oh, that they wait. Baby, God, the place for real. For sweetie, to pass it away, to pass it out, oh, baby, you do it your way. Baby, you what I like it. Oh, I go make you famous, even if they beg us. Oh, you go ahead, I do let us. They make you beg us, they beg us. Oh, you go ahead, It's time for here for you. Every melody can turn into a symphony instantly. I know that she was meant for me, even when it was so hard to see. I know that we could be. You did the same for me, now I'll be there for you. Magic, magic, magic. Could you ever imagine? Don't give up, don't give in. Keep going until the end. Say, magic. Could you ever imagine? I'm just a humble little sailor with too much to prove. But my boat's so small and the ocean's so huge. And I don't wanna go half on a dream, so I need you to be part of my team. I could never pretend or act like it's just me. Without you, where would I be? Imagine. Could you ever imagine what you've done? Now you live and you walk through all of your things.
And the last slide was the other thing I did in Tanzania. I climbed Mount Kilimanjaro, which was probably more challenging than anything else I did there. But it's pretty amazing to live there for 3 years and have an opportunity to really know the people, the culture, to travel. So that's the end of my talk. Thank you for listening. If you have questions, do we have time for more questions?
Sure.
Like an outside educator, what were some of the more frustrating barriers to effective education?
Well, it's interesting. So I had some amazing faculty support, but then there were some faculty that were very difficult that, you know, I'd have to step back and realize that the faculty, the way they learned was not the supportive way that we teach here in most Western countries. It was much more punitive. And sometimes the teachers, some of the teachers wouldn't even show up for class, and the students would just be left there. So that was frustrating. Fortunately, though, there were enough faculty that were very supportive and didn't and showed the same kind of support for their students that those of us volunteers did. So that was one frustrating thing. And then, you know, trying to do the clinical mentoring piece with 44 students when, you know, their clinical mentoring piece was inadequate was challenging. And I would say the first 6 months I was there, I floundered until I could figure out the way to sort of divide them into groups, do some post-clinical conferences, so they had to present patients. The physicians had a little bit more clinical, because in the physicians' world in some of these countries, the physicians do more clinical bedside teaching than the faculty, nursing faculty does. So, and then, you know, trying to develop a relationship with the clinical staff, the labor and delivery, and the postpartum ward in those places where I was actually, you know, I didn't want to come in there and have them feel like I knew everything, because they taught me so much. I'd never done a breech delivery. They taught me so much. And so developing a relationship where they felt like, you know, they were part of the equation for teaching and training the students. sometimes that was challenging.
So this is all very much a global scope. Could you answer any questions about how to address this issue in the United States at all?
I'm sorry.
How to address this issue in the United States? Because we study these statistics in my population and society class, and there's a lot of racial disparities, and like half of these deaths are African American, from what I read in the stats, and you're 4 times more likely to die if you're African American. Do you have any insight on that issue and how we can address that? I know it's a very complex social issue.
It's a very complex social issue with an administration that's, in my opinion, in my political opinion, is taking us back instead of forward to try and address those issues around institutionalized racism and inequity in care. I don't have an answer for you.
What did you learn or observe there that you would say we could do better here? What could you take back from Tanzania to the United States?
Well, it's the same thing. The UN, new development goals are talking about equity in health care for all women, for all people. We don't have that here, just what he's saying. If you look at the statistics about what women in this country are dying, it's the poor communities, it's the rural communities, and more more midwifery care. In many industrialized nations, midwives do most of the normal deliveries, and the obstetricians do the cesareans and the difficult deliveries. In this country, about 10% of babies are delivered with midwives.
Well, the cutback and expanded Medicare, Planned Parenthood is really going to be suffering because that funding helps provide family planning and female reproductive care
for people who can't necessarily afford it.
So, in the United States, the political environment determines what we have available as far as health care. And currently, the trend is to cut back health care that makes services available to people more at risk because of their income, because of their location, because of their color. The current trend is to cut back services to those areas. So, until that changes, I think we're going to see, a continued problem.
So as healthcare providers, we're constantly writing to our legislators, and, in Seattle, our Planned Parenthood in Seattle never had too many folks coming to, they do abortions in the one clinic in Seattle. And now, with the climate, there's so many people that are pro-life that come and interrupt access to care for these in Seattle. So if it's happening in Seattle, it's happening all over the country where people are emboldened to come and interrupt these services. And of course, Planned Parenthood, not every Planned Parenthood does abortions. They provide so many other services beyond abortion.
Going back overseas again, male nursing.
That was yes, that's a very interesting thing. My first class, most of my classes were 2/3 male. And my first class, it was kind of stunning, and I was like, oh, I'm not sure how I'm going to feel about this. But, they were great. I mean, anywhere you have students that take the path of least resistance, and you're not even sure why they chose nursing, and then you have students that just shine. My first clinical class, it was only 7 senior students, and that was fantastic. But they had this reputation of not showing up to clinic because they didn't have any accountability. So I just laid down the law and said, if you show up, I'll show up. And because I had this one incredible, motivated, I know he's going to be a mover and a shaker, male student, I think he raised the bar for the other 6 students. And they shined. They just did amazing in their clinical and in just their enthusiasm and motivation. And, you know, I mean, I have these male students say, I love midwifery.
I was really impressed in your slides by, like you said, the motivation, the attention that everybody was paying to the lessons that were going on, and also the fact that there were so many males in the group. But what really impressed me was, and I'd like you to comment on this, that it seems to me like Uganda is really making some progress. And I was thinking, wow, if all these people are going to go out and do the kind of work that you've trained them to do, that's going to make a big impact in Uganda. So do you feel like that's the case? I mean, it really looks...
Well, we're hoping they are. I mean, I didn't have very many pictures of the students in the diploma program. Tend to be lower socioeconomic, and they always have to be dressed in their uniforms. They can't. Those students can't come to class. Whereas the bachelor's degree students, this is a private Catholic university, so you can just see by the way they're dressed and everything. They're a little bit higher socioeconomic, but they don't have a choice necessarily where they're going to work. The Ministry of Health assigns them, so they are going to go out to these rural areas. And one of the things that we talked about a lot about, okay, they come to me and call me Madam, and I hated that, but, you know, it's a term of respect. We saw a woman being slapped in labor. So it's like, well, how'd you feel about that? And they talk about it. But then to take it a step further, what are you going to do when you're assigned out in some rural area and your senior nurse is doing that? How are you going to handle that? Because, you know, there's that hierarchy and respect for elders, and so, you know, I think many of those students will step up and make a change, but some of them are going to find it hard. But yeah, I think there will be definitely some improvement.
Yeah, Tanzania is a pretty impressive country, actually, in a lot of ways. It's not a very wealthy country, but it's politically a very interesting country because it's quite a democratic country with transitions from one political party into the next. They had a really good base, I think, with President Nyerere when he established Ujamaa socialism in the country, and so with some really good lessons that we could learn about conflict of interest among politicians, avoiding conflict of interest. So there's a lot of really exciting things going on, I think, in Tanzania, and I'm really thankful that you could bring to us your experience there. So before I conclude and thank Deb one more time for her talk tonight, I want to just do a couple of logistical things. So first of all, for those of you who are taking the class for credit, remember that you've got 2 papers that you have to submit before the end of the class, one on 2 different lectures that you observed. And if you have forgotten what the instructions are for those papers, I brought them with me so you can come and ask me for a copy of that. Secondly, I'd like to mention that next week we're going to hear from Lee Taggart, and she is going to talk about sustainable community development in Morocco's high Atlas Mountains. Lee is a health program coordinator in Billings. She's going to come in from the other direction, and she is a graduate of our Master's in Public Health program here at the University of Montana. So we'll move a little bit north from East Africa to North Africa in our discussion next week. So once again, please join me in thanking Deb for a really entertaining and interesting presentation. Thank you very much.